Succinylcholine is a strong nicotinic acetylcholine receptor agonist. Succinylcholine is not metabolized by acetylcholinesterase. It's metabolized by another enzyme called butyrylcholinesterase, and it's rare, but if patients are deficient in this enzyme, they can have a prolonged paralytic effect from succinylcholine. Once succinylcholine reaches the neuromuscular junction, it binds to nicotinic receptors, and it causes sustained depolarization, and this is what makes succinylcholine unique. When the muscle is depolarized, it's unable to contract, and not only that, you cannot make it contract by increasing the amount of acetylcholine at the neuromuscular junction. No matter how much acetylcholine you add, the muscle is already depolarized and it's unable to contract. And so because of this unique mechanism, because succinylcholine depolarizes muscles, you won't see a fade with train of 4 like you do with the non-depolarizing agents. This phenomenon is due to the fact that you can overcome the block of non-depolarizing blockers with more acetylcholine. You can't do that with succinylcholine, so you don't see the fade. Here's a depiction of how succinylcholine works. It binds to the nicotinic receptor and depolarizes the muscle cell that is attached to the receptor. This is going to render the muscle unable to contract. Because succinylcholine is not hydrolyzed by acetylcholinesterase, it will maintain the muscle in a depolarized state. Also, if you inhibit acetylcholinesterase and boost the levels of acetylcholine, that won't help because the muscle is depolarized and it can't contract even if acetylcholine were able to get back into the receptor binding site. Succinylcholine's claim to fame is that it has the fastest onset and washout of all of the MBMAs. The onset of action is within 30 seconds, most patients are paralyzed within 1 to 2 minutes, and the duration of the usual dose of succinylcholine is only about 10 minutes. So because of these properties, it's usually given as a bolus for temporary paralysis. That's where it's most useful when you want to quickly, but only temporarily, paralyze a patient. When you administer succinylcholine, it will initially cause fasciculations of muscles from depolarization. This will be followed by flaccid paralysis. Importantly, succinylcholine cannot be reversed like the non-depolarizing NMDAs. You have to wait for it to wash out. Over time, it will eventually be metabolized by butyrylcholinesterase. Once again, if you look at this depiction here, succinylcholine depolarizes the muscle cell, so even if you inhibit acetylcholinesterase and boost the acetylcholine levels, that won't cause a muscle contraction because the muscle is depolarized. One of the most common indications for succinylcholine is what's known as rapid sequence intubation. This is the standard practice for emergent intubation of patients with respiratory failure who need to be placed quickly on mechanical ventilation. The idea is to use drugs that quickly render the patient sedated and flaccid, and the two drugs that are usually used are etomidate and succinylcholine. Etomidate is a drug that I talk about in the video on intravenous anesthetics. It quickly sedates patients without changing the blood pressure. And then for paralysis, succinylcholine is the ideal drug because it has a quick onset, so the patient will be paralyzed so that a breathing tube can be inserted like what's shown on the screen. But then once the patient is on the ventilator, the paralysis will quickly wear off, so the patient won't remain paralyzed for a long period of time. The main side effect of succinylcholine is hyperkalemia. Whenever your muscle cells depolarize, some potassium leaks out. When you give succinylcholine, you have diffuse muscle depolarization throughout the body, and that causes leakage of potassium into the plasma. Usually the increase is on the order of 0.5 to 1 milliequivalent per liter. Most patients can tolerate this, but you have to be careful if you're giving succinylcholine to a patient who might have hyperkalemia. Two other special patient populations when it comes to succinylcholine are burn patients and stroke patients. In patients with burns or strokes, there's an upregulation of nicotinic acetylcholine receptors on muscles, and this can cause even more potassium than normal to leak out, so there's a higher risk of hyperkalemia. So succinylcholine is often avoided in burn patients and stroke patients for this reason. Another potential side effect of succinylcholine is malignant hyperthermia. I talk about this in detail in the video on postoperative complications, but it's a reaction to certain drugs, usually either inhaled anesthetics or succinylcholine. Patients develop fever and diffuse muscle rigidity. And then lastly, succinylcholine often causes myalgias. Half of patients who receive the drug will have muscle soreness afterwards. This can be treated with non-steroidal anti-inflammatory drugs. There are two mechanisms by which neuromuscular block can occur with succinylcholine. These are called the two phases of succinylcholine block. So let's talk about this now. Phase 1 block is what we've been discussing up until now in this video. This is the typical phase you see with succinylcholine when you use bolus dosing, such as during rapid sequence intubation. The muscles will depolarize, there's an initial contraction and then flaccid paralysis, and you cannot overcome this block with more acetylcholine. You can't use acetylcholinesterase inhibitors like neostigmine because they won't work. Even when you flood the neuromuscular junction with acetylcholine, it does not overcome phase 1 block. In addition, you will not see a fade if you apply a tranophore to the patient. Remember what I said earlier, fade with tranophore is evidence of a non-depolarizing blocker. That does not occur with the depolarizing blocker succinylcholine when the patient is in a phase 1 block. Phase 2 block with succinylcholine only occurs after large or sustained dosages, which we rarely use in modern practice. What happens in a phase 2 block is the muscle cell membrane repolarizes, but the receptors have been desensitized from binding succinylcholine. As a result, the muscle no longer reacts normally to acetylcholine. In contrast to a phase 1 block, however, you can overcome a phase 2 block with more acetylcholine. The receptor is desensitized, but if you give enough acetylcholine, you can generate a muscle contraction. What this means is that phase 2 block of succinylcholine behaves like blockade with non-depolarizing drugs like we talked about in the beginning of this video. You can overcome the block with neostigmine and acetylcholinesterase inhibitors. You can also see a tranophore fade in phase 2 block, which is not present in phase 1 block. So how do you know if a patient who is receiving succinylcholine is in phase 1 or phase 2 block? Well, first of all, you should suspect a phase 2 block if succinylcholine is given as an infusion or in large doses, because these are the circumstances when phase 2 block usually emerges. And then clinically, you can tell the patient's in a phase 2 block because their muscles will behave as if they have been treated with a non-depolarizing drug. You can see that fade with tranophore, which is not present in phase 1 block. It's only present in phase 2 block or among patients who have received a non-depolarizing drug. The management of phase 2 block is a high-level topic, something that anesthesiologists have to deal with. The block can be reversed by acetylcholinesterase inhibitors like neostigmine, although this practice is controversial because of adverse effects related to neostigmine, or you can simply wait until the block resolves. I'll finish with this slide and mention some of the common clinical uses of neuromuscular blocking agents. One is intubation, like we talked about earlier. You want to paralyze patients when you're intubating them so that you can manipulate the jaw and easily insert the breathing tube. During surgery, you want patients to be paralyzed so that they won't move during delicate portions of the operation. And then lastly, in the ICU, patients with severe hypoxemia can be paralyzed. This prevents spontaneous respiratory efforts so the patient won't get out of sync with the ventilator, and this can improve respiratory status. So patients who have severe hypoxemia sometimes need to be paralyzed to improve their oxygenation until whatever lung process is going on has resolved. And that concludes our module on neuromuscular blockers.